I call the meeting to order. Welcome to meeting number 14 of the House of Commons Standing Committee on Health. Today we'll be meeting for 2 hours to hear from witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. I'd like to begin by thanking our witnesses for being with us today and for your patience as you waited the delayed start of this meeting because of our votes. There's, I understand, a fair possibility that we will also be interrupted because of votes as well, but we very much look forward to hearing from you, and again, thank you for your patience. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021, per the Directive of the Board of Internal Economy on March 10th. Except for members who are at their place during the proceedings. For the benefit of the witnesses and members, please wait until I recognize you by name before speaking. For those participating by video conference, please click on your microphone icon to activate your mic and mute yourself when not speaking. For those of you on Zoom, you have the choice at the bottom of your screen of either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. Reminder that all comments should be addressed through the chair, and you are discouraged from taking screenshots of your screen. Everything that we do here will be made available on the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. And I would like to now welcome our witnesses who are with us this afternoon for 2 hours as an individual. We're pleased to have Dr. Isaac Bogosh, an associate professor of medicine at the University of Toronto, staff physician in infectious diseases at the Toronto General Hospital. As an individual, Dr. Amelia Liana Falcone, the Director of Post-COVID-19 Research Clinic, Montreal Clinical Research Institute, attending physician, infectious diseases, Centre Hospitalier de l'Université de Montréal. From the Canadian Association of PPE Manufacturers, the President Barry Hunt. From the Canadian Cancer Society, Stuart Edmonds, Executive Vice President, Mission, Research and Advocacy, and Kelly Mazzotti, Vice President Advocacy. From the Canadian Mental Health Association, Rebecca Shields, Chief Executive Officer, York and South Simcoe Branch. And from the Neighbourhood Pharmacy Association of Canada, Sandra Hanna, Chief Executive Officer. Again, thanks to all of you for appearing today. We're going to begin opening remarks from each of you in the order that you are listed on the notice of meeting. As you've probably already been advised, if you could limit your opening remarks to 5 minutes, that will allow us more time to ask questions. So Dr. Bogosh, we're going to start with you. Welcome to the committee. You have the floor for the next 5 minutes.
Thank you so much, and thank you for the invitation and the opportunity to speak at this seating of the House of Commons Standing Committee on Health. My name is Isaac Bogosh. I'm an infectious diseases physician and scientist. I'm based out of the University of Toronto and the Toronto General Hospital, and I've worked closely with various levels of government in both formal and informal capacities during this pandemic. As we trudge forward, somewhat exhausted from the last 2 years, it's still appropriate to acknowledge that COVID is not going anywhere anytime soon. And we will see an ongoing waxing and waning of disease activity in Canada and also in communities around the world. And this is, of course, going to be associated with morbidity and mortality, unfortunately. COVID is obviously a global issue. I'm going to focus my talk locally. With that in mind, how do we plan ahead so Canadian society is not disrupted significantly by future waves or variants? Or said another way, how do we live with COVID? And by live with COVID, I mean, how do we protect all Canadians, including and especially vulnerable individuals in at-risk communities? Now, I'm approaching this with the understanding that we should never close businesses or schools again. We have the tools to avoid this. And this involves being proactive and not getting caught flat-footed. I see two main pillars that we should be addressing. Pillar one is building resilient healthcare systems, And pillar two is really fostering resilient communities and environments. So just focusing on the first one, building a COVID resilient healthcare system. This really involves proactive vaccine and therapeutic procurement and perhaps production. We saw early on our inability to produce these products locally was a true health security threat. And now we're taking steps to remedy this. But we still need momentum on that front. Related to vaccine and therapeutic procurement is vaccine and therapeutic rollout to the population. We've got to continue to be nimble and fast with policy and be able to keep abreast of emerging evidence in real time and convert this evidence into sound policy. It also means rolling out vaccines and therapeutics in an evidence-based and equitable manner with as few barriers as possible. Now, that might seem abstract, but a good example of this is how in parts of the United States, they're going to roll out COVID treatments at some pharmacies. Pharmacies are present in most neighborhoods. They're staffed with knowledgeable healthcare professionals. They often don't require an appointment. They're often more accessible than traditional routes of healthcare. And COVID therapeutics at pharmacies without a prescription is just one of an infinite number of examples of how we can lower barriers to healthcare and provide fast, meaningful, high-quality healthcare to populations. The other big issue in the healthcare system is preparing for surge capacity. This involves outpatient care, hospital care, of course, ICU care. We will see more variants, we will see more waves, and eventually we're going to have a real flu season coupled with COVID, and it's going to be a challenge. We can't continue to cancel scheduled surgeries every time we have a wave and our system is stretched. So it's vital to have medium and long-term strategies to build more beds and to staff them, not just with doctors, but also with allied healthcare providers. This involves meaningful investments, making the healthcare sector a more attractive place to work, and of course, less red tape, preventing skilled healthcare providers who have trained in other countries and are now living in Canada from working. Let's focus our attention now on building more resilient populations and environments. Easy to say, hard to do. The lowest hanging fruit is normalizing mask use during COVID surges. This is a light touch intervention, and while of course masking is not perfect, it still helps the individual, it helps vulnerable people, it helps the community, and I think it's is about as easy as it gets. Additional strategies is further study on how we can build safer indoor spaces. This is where COVID and other respiratory viruses transmit. That, for example, includes improving indoor air quality. This involves an interdisciplinary approach with social scientists, engineers, infection specialists, building owners, building managers, and others. It's not just as simple as installing HEPA filters. And lastly, I think an area for improvement includes enrolling social scientists and behavioral change experts and communication experts into the larger pandemic plans. We're going to continue to see rapid scientific advancements. We're going to see variants. We're going to see waves. We're going to see a fair bit of the unknown. Policy has to be data-driven and relevant, and it has to keep up with our lightning pace of discovery. Some of what's true now may not be true in the near future, and we need public trust and public buy-in. Behavioral scientists and communication experts can help communicate change, adaptation, communicate the unknown in an age, language, and culturally appropriate manner. I think they'd be invaluable in our future pandemic response. I have several other thoughts, and I'm happy to keep the conversation going during the question period. I thank you for your time.
Thank you, Dr. Bogosh. Next, Dr. Falcone, you have the floor. Welcome to the committee.
Thank you, Mr. Chair and members of the committee for offering me the opportunity to speak with you today. The thoughts that I will be sharing with you reflect my experiences during the COVID-19 pandemic as an infectious diseases specialist, researcher, and director of the post-COVID research clinic of the Montreal Clinical Research Institute. The views shared today are my own. The COVID-19 pandemic began 1 year after I was recruited to the Montreal Clinical Research Institute. Prior to this recruitment, I spent 8 years at the United States National Institutes of Health, completing my infectious diseases training within the National Institute of Allergy and Infectious Diseases, which is led by Dr. Anthony Fauci. During this time, I also obtained my PhD at the University of Cambridge. This combined training in medicine and basic science laboratory research was essential in allowing me to anticipate at the start of this pandemic that there would be long-term sequelae of COVID. As such, I submitted a proposal for funding to CIHR in May 2020, which was unfortunately not retained. However, 8 months later, I obtained sufficient funding from the Quebec government to allow for the opening of Quebec's first long COVID research clinic. This research clinic represents a novel clinical infrastructure where every patient is enrolled in a research protocol, allowing for comprehensive clinical evaluation, parallel data collection, human specimen biobanking, and by extension, the completion of laboratory research almost simultaneously within the same building. We are therefore able to perform translational research, that is, research where we have the privilege of learning firsthand from the lived experience of patients with long COVID and can then use this information to inform our research questions in the laboratory. Selon l'OMS, les affections.
According to the World Health Organization, post-COVID-19 or long COVID illness is a condition that occurs in people with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months after the initial infection, with symptoms that can last at least 2 months and cannot be explained by any other diagnosis. Symptoms may occur after an acute asymptomatic infection or after initial recovery from the acute phase of the infection. Symptoms may also fluctuate over time. The diagnosis of long COVID is therefore complex and sometimes requires longitudinal follow-up. In addition, the symptoms associated with long COVID are numerous and many, such as fatigue and shortness of breath, overlap with other diseases. Some patients cannot return to work. With a conservative prevalence estimate of 10% after a 3-month post-COVID follow-up, the number of patients with the disease far exceeds the capacity of established specialty clinics in Canada, which can be costly to the Canadian healthcare system, as these patients may develop additional complications or undergo multiple tests and referrals to multiple specialists.
Long COVID is a complex diagnosis to make, made even more complex by the fact that we do not yet have a full understanding of the cause of this condition. The management of long COVID is also challenging as it requires a multidisciplinary approach, and we are currently lacking specific pharmacological treatment options. Without fully understanding the mechanisms that underlie the novel disease entity that is long COVID, it is challenging to identify reliable biomarkers that may either predict who will develop long COVID or help make a long COVID diagnosis. These biomarkers are especially important in the context where COVID testing by PCR is not available to all. Most importantly, the understanding of the disease mechanism is ultimately essential to identify therapeutic targets that may quicken the recovery from long COVID, especially if these treatments are administered early on in the course of the disease. It is within this context that we need to be forward-thinking and maximize our learning when faced with a new clinical entity such as long COVID, or even a new infectious disease. One way to maximize this learning with a structured and efficient approach is through a translational research infrastructure that is integrated into clinical care pathways. The integration of a research clinic model, such as the one established at the Montreal Clinical Research Institute, into specialized centers across Canada would be essential for the rapid identification of diagnostic biomarkers and new therapeutic targets. This model would be even more effective if it were integrated into a network that would use standardized protocols and have an established infrastructure for real-time data sharing and integration. With this coordinated and rapid approach, we would further distinguish ourselves as a country, not only in the context of long COVID, but also in the management of other complex and chronic diseases. In addition, such an infrastructure would foster collaboration between government, industry, and academia at both national and international levels. Undoubtedly, these efforts will also allow us to be better prepared to rapidly manage the next pandemic. I thank you again for the opportunity to speak to these issues, and I welcome any questions that you may have.
Thank you very much, Dr. Falcone. Next, we're going to hear from the Canadian Association of PPE Manufacturers. Mr. Hunt, you have the floor for the next 5 minutes.
Thank you, Chair, and thank you, Committee, for the invitation to speak here today. The Canadian Association of PPE Manufacturers, CAPM, is made up of 30 Canadian-controlled private to produce PPE here in Canada. At the start of the pandemic, Canada had no N95 manufacturers, testing labs, or national standards. Canadian hospitals only bought N95s from multinationals that sourced from foreign countries. The N95s in the national strategic stockpile had expired long ago, and most had been destroyed. When the pandemic hit, China, Taiwan, and the US banned exports of N95s and the US locked Canada out of NIOSH N95 certification. When the chips are down, we simply cannot rely on multinationals or foreign countries to protect our country. CAPM was created to ensure Canada would never again be vulnerable to foreign countries and multinationals for the supply of PPE. When COVID hit, Canada was desperate for PPE, but the multinationals could not deliver. The government response was threefold. One, compete in the world market to fly in billions of dollars of overpriced PPE, 30% of which was found to be defective, counterfeit, or contaminated. Sole source multi-year contracts and grants to the same two multinationals, 3M and Medicom, who could not deliver foreign N95s to Canada when Canada needed them most. And three, a call to action to Canadian business to create a new domestic PPE industry. SMEs make up 99% of the Canadian economy and employ 90% of the private workforce, 10 million Canadians. Canadian SMEs are the economic engine of Canada, and we're here to help. But today we need your help. 3M and Medicom represent the 1%. Multinational manufacturers of foreign goods invited now by government to manufacture N95s here in Canada with plants bought and paid for by Canadian taxpayers. They were given sole source contracts in the order of $600 million to sell N95s in competition against Canadian industry. This undermines the entire domestic Canadian PPE industry. So despite promises made by the government to support the new PPE industry with flexible procurement, Canadian locked hospital contracts for almost 2 years now. Unless government reverses course, we will continue to be locked out for the next decade and perhaps forever. The federal government says they no longer have an appetite for PPE procurement. In other words, no contracts for Canadian industry. Over 100 Canadian SMEs answered the government call to action. 70% of them are now out of the PPE business. Many are now bankrupt. Others are on the way to bankruptcy. The remaining CAPM SMEs committed to sustainable industry can now produce 800 million high-quality N95s, 2 billion medical masks, and millions of reusable N95s every year. However, while Canadian industry is suffering from lack of hospital contracts and promised government contracts, they now face additional unfair competition from dumping and unfair labor practice because of the pandemic tariff exemption for PPE that has long outlived its usefulness. SME innovation drives Canada's economic growth. There's been more innovation in Canadian PPE in 2 years than in the previous 50 years worldwide. We've created new filter materials, new elastomeric N95s that look like cloth masks, and a new national CSA standard for N95s with the highest performance requirements in the world. And we've developed the world's first industry standard for bioaerosol masks to protect the general public from virulent airborne disease. There is no stockpile today of suitable bioaerosol masks intended for the public, and we believe this is a major failing in emergency preparedness. 14 major variants of concern have already emerged with no signs of stopping. We need to prepare for the very real possibility that someday we may face a highly virulent strain. Canada's 8-week stockpile of N95s would be gone in 8 days, and we have nothing in our stockpile to provide to our 8 million children. A sustainable domestic PPE industry is absolutely the right thing for Canada. It has overwhelming public support, but it does not have the government support to make it a reality. We were unprepared 2 years ago for a virulent airborne pandemic. We're still unprepared today. We heard testimony from PHAC that we are now well situated with N95 respirator domestic manufacturers. I can assure you we are not. We need to support our domestic PPE industry now, or it won't be there when we need it. I thank you.
Thank you, Mr. Hunt. Next, we have the Canadian Cancer Society, Mr. Edmonds and Ms. Mazzotti. Who's going to kick us off?
I'm going to start, Mr. Chair. And thank you to the members of the committee for the opportunity to present today. My name is Dr. Stuart Edmonds. I'm the Vice President, the Executive Vice President of Mission, Research and Advocacy at the Canadian Cancer Society. And with me today is Kelly Mazzotti, Vice President of Advocacy. With respect and gratitude, I'm joining you today from the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13 of the Mississaugas of the Credit. 2 in 5 Canadians are expected to be diagnosed with cancer at some point during their lifetime. Cancer is a leading cause of death in Canada, accounting for 28% of all deaths. Today, we will share with you how the COVID-19 pandemic has impacted the cancer experience of many people living in Canada and their loved ones. multiple waves of COVID-19 have put a tremendous strain on Canada's healthcare system. To ensure that there was sufficient health system capacity during surges of COVID-19, hospitals across provinces and territories were directed to pause all their procedures deemed non-urgent, including cancer screening, diagnostics, and surgeries. This has subsequently led to a growing backlog of delayed cancer screening, diagnostics, and surgeries, which means people living with cancer are waiting longer to receive care. We know that when cancer is found early, it's often easier to treat. Delays in screening and diagnosis may result in poorer patient outcomes, including an increased risk of death. The impact of COVID-19 on cancer prevention, diagnosis, and treatment will be felt for months and years to come. Studies are starting to be published on how COVID-19 related delays impact people living with cancer. A recent Ontario modeling study published in the Canadian Medical Association Journal estimates that longer wait times for cancer surgery may lead to shorter long-term survival. This study highlights the importance of maintaining timely access to cancer surgery to prevent the harmful impacts of delayed care on people living with cancer, even during times when health resources are constrained. In CCS-led surveys between July 2020 and March 2022, people with cancer reported having their cancer care appointments postponed or disrupted. Almost half the patients reported disruptions in the first wave of the pandemic. And while disruptions dropped over time, they have increased slightly since August 2021. In our last survey, 1/5 of respondents reported disruptions to their cancer care appointments. For many patients, there is a window of opportunity for treatment. Delays in appointments and treatment may lead to missed opportunities, and the cancer may have spread. CCS-led surveys found that people living with cancer had higher rates of anxiety during the early stages of the pandemic. And the sense of anxiety was higher amongst caregivers, with more than 3/4 of respondents stating they were more anxious than normal. CCS continues to hear from people affected by cancer who say they are frustrated by a lack of access to their healthcare teams. And although this concern has lessened over the course of the pandemic, we're still supporting them through our support programs, and we're still hearing from people who feel forgotten. We need federal leadership. CCS was pleased to see the introduction of Bill C-17 on Friday, which would provide an additional $2 billion to address immediate pandemic-related healthcare system pressures, particularly the backlogs of surgeries, medical procedures, and diagnostics. We encourage all parties to work together and pass Bill C-17 promptly. Every moment matters, and has been evident by the recent CMAJ paper, cancer is not waiting, neither should the government. CCS also urges the federal government to continue to make necessary investment to expand the domestic capacity of vaccines, therapeutics, and other life-saving medicines. We were pleased when the government launched the Biomanufacturing and Life Sciences Strategy last July with a commitment of $2.2 billion expected to be allocated over 7 years. One of the strategy's key investments created a $250 million new funding stream, the Clinical Trials Fund. CCS welcomes this funding and looks forward to the details on this development and implementation of this fund. These investments are critical to keep Canada at the forefront of new innovations in healthcare and provide really early opportunities for Canadians to access potential game-changing new therapies and diagnostics. And now I want to turn it over to my colleague, Kelly Masotti.
Thank you, Stuart. I want to acknowledge that I'm joining virtually from Ottawa, which is the unceded territory of the Algonquin and Anishinaabe Nation. The COVID-19 pandemic has also shown us that substantial gaps persist in accessing palliative care, particularly at home or in the community. Caregivers for a loved one at home experienced a sharp increase in their duties, exacerbating the need for greater psychosocial, physical, and practical support for caregivers. As a member of the Quality End of Life Care Coalition of Canada, we urge the government to continue to implement the Framework and Action Plan on Palliative Care, including an Office for Palliative Care to help coordinate aspects like data collection on palliative care, and to continue to invest in palliative care research. Finally, we encourage the federal government to play a role in ensuring that Canadians are set up for success in making healthy and informed choices that make it easier to live smoke-free, keep a healthy weight, adopt a healthy diet, be physically active, be sun-safe, and reduce alcohol consumption. The federal government can play a strong leadership role in implementing policies and programs that will have an important population health impact. We'd also like to take the opportunity to thank the government supporting the extension of the employment insurance sickness benefit. This extension of at least 26 weeks will change the lives of Canadians. We look forward to continuing to work together to implement these very important recommendations for people living with cancer and living beyond cancer, including encouraging all parties to work together and pass Bill C-17 promptly, improvements to the delivery of palliative care, the implementation and the extension of the employment insurance sickness benefit, and to see the clinical trials fund be implemented. We thank you very much for your time today and look forward to your questions.
Thank you, Ms. Mazzotti. Mr. Edmonds, next from the Canadian Mental Health Association, Rebecca Shields. You have the floor for the next 5 minutes.
Thank you, Mr. Chair, for the opportunity and to the committee to present today.
Point of order, Chair.
Sorry.
Just hold on a second there, Ms. Shields. Yes, go ahead, Mr. Barrett.
Yeah, my apologies for the interruption, Ms. Shields. And through you, Mr. Chair, bells are ringing in the chamber for a vote. At the last time at this committee that we discussed this matter, some members expressed that in future they would not grant unanimous consent because it's their absolute privilege to vote in person in the chamber, which is 100% correct. I would just ask through you, Chair, if we could seek unanimous consent of committee members to hear the opening statements of all witnesses, if time allows, and then proceed over to the House to vote. Just in case that any of our witnesses aren't able to join us, following the conclusion of that vote in the chamber.
Okay, thank you very much, Mr. Barrett. Colleagues, Mr. Barrett is quite right. Without the consent of the committee, we're actually obligated to suspend the meeting. So, do we have the consent of the committee to proceed to hear the remainder of the opening statements before suspending? I understand there is consent in the room. Thank you very much for that, Mr. Barrett. Ms. Shields, please continue.
Thank you very much. I think we all know and have all heard about the impact of the pandemic on the mental health of Canadians. What I want to focus my remarks on today are two specific topics that I think the federal government can help. I was very pleased to see that the federal government assigned a new Minister of Mental Health and Addictions. And my remarks are going to be specific to some of the deliverables of that position. Our research shows that 1 in 5 Canadians felt that they needed help with mental health during the pandemic, but didn't receive it because they didn't know where to get it. They didn't think that help was available, or they couldn't afford to pay for it. And so, beyond just building more services, I want to talk today a little bit about how. The first I want to talk about is youth services. One of the deliverables was to introduce a new fund for student mental health that will support the hiring of new mental health care counselors, improve wait times for service, and increase access overall, and enable targeted supports for Black and racialized students at post-secondary institutions. This is critical. 2 times the number of children and adolescents experience depression and anxiety since the pandemic began. 11% of all people that experience homeless are youth, and 1 in 4 youth have clinically elevated symptoms of depression, and 1 in 5 have clinically elevated symptoms of anxiety. 70% of all mental illness starts in youth at the ages of 12 to 17. However, what I'm worried about is that the government will give the money to colleges and universities to hire mental health counselors, creating yet another silo of care that is not integrated. We all hear that the major challenge is that people don't know how to get services, rather than funding an already established system of care. And I want to show an example of how this works. In its wisdom, the federal government, through IRCC, funded our agency to provide holistic mental health care through settlement agencies and through welcome centers since the pandemic. Since the start of that program, we've served 292 clients, and 85% have experienced an improvement in their depression-related symptoms, and 89% experienced improvement in their anxiety-related symptoms. and remain connected to their settlement services. So integrating care is vital rather than establishing a whole new section where we have to then build relationships rather than connect them into a whole system of care. The second area I want to talk about is the increase of substance abuse. I want to position this, though, in terms of a population perspective, because COVID did not affect the genders or the populations the same. In fact, it was men who had higher rates of problematic alcohol abuse, up 28%, where women were only 18%. For men, they had problematic cannabis use, up 39%, and women just a little bit less. But overall, we also saw that females, especially females with children at home, had higher rates of anxiety and depression than men. And they reported that men had more issues with social isolation and finance, where women had more issues with finance and caring for one children. So the situations are very different, and one size fits all is not the solution. So I urge the federal government, when they are designing a system of care to deal with substance abuse, to look at local solutions rather than broad public health strategies. They need to invest in local communities where they can target populations directly. So I want to give another example of how this can work. When we look at, whether you look at OHTs or you look at health authorities, most of them have population-specific groups that bring together agencies to come together to deal with these issues. We have to leverage these and provide small community grants to be able to access these populations rather than broad scale that reach the norm, because COVID, as we know, impacted the mental health and also the health of newcomers and minority populations far more often, or in far greater rates than white Canadians. So really, in summary, what I want to say is integrate care with local existing and do hyper-local responses. Thank you.
Thank you, Ms. Shields. And finally, the Neighbourhood Pharmacy Association of Canada, represented by their CEO, Sandra Hanna. You have the floor, Ms. Hanna.
Thank you, Mr. Chair. Honourable members, thank you for the opportunity to present to you. I am actually first and foremost a practice pharmacist to work alongside my health system partners and governments in our collective efforts to meet the needs of Canadians as we weather the storm of the COVID-19 pandemic over the past 2 years. Today, I join you as the CEO of the Neighbourhood Pharmacy Association of Canada, a not-for-profit trade association that represents leading pharmacy organizations, including chain, banner, long-term care, specialty pharmacies, and grocery and mass merchandisers with pharmacies. We advance healthcare for Canadians by leveraging close to 11,000 pharmacies across the country and almost every Canadian community as integral community health hubs. Pharmacies are often the first and most frequent touch point Canadians have with the healthcare system, and 95% of Canadians live within 5 kilometers of a pharmacy. Canada's community pharmacies dispense over 750 million prescriptions annually, deliver the majority of influenza vaccinations each year, and in the past 12 months alone have administered over 18 million COVID vaccinations to Canadians, reducing rate of illness and strain on an already overwhelmed healthcare system. As we continue to navigate the steady stream of challenges caused by the pandemic, and as our federal political leaders reflect on the future needs of our healthcare system to support our citizens, treat those in need, and protect our most vulnerable, there are even more opportunities to unlock the potential of pharmacy as a partner in communities across the country as we look to building resilient health systems. Pharmacies and the robust supply chain that serves them have demonstrated unwavering commitment to Canadians and health systems throughout the pandemic as critical partners in the timely delivery of products and services, in mitigating supply chain challenges early on in the pandemic, and in helping Canadians to access vaccines and tests conveniently in virtually every community across the country. Without our services, medicine simply cannot get to Canadians. Our priority is and always will be maintaining and continually improving access to prescription medicines for Canadians. While there are differences in opinion on a number of key files, including national pharmacare programs or pricing reform on patented medicines, we can all agree on one thing, and that is that all Canadians should have access to the medicines they need. Recent research demonstrates that while 82% of those surveyed support a national pharmacare plan, 70% of those supporters are opposed to a program that would replace their existing drug plans. In fact, 80% of those surveyed continue. This priority must be helping those who do not have coverage and those with insufficient coverage, including those with rare diseases, without disrupting the majority of Canadians who already do have drug coverage. By taking this approach, we can minimize unnecessary expenses and costs to taxpayers and allocate money to the many other critical healthcare priorities that we're discussing today. The federal government can demonstrate leadership by establishing national principles to ensure an equitable approach while maintaining the integrity of existing plans. The government has previously also cited COVID-19 as a primary reason for delaying the implementation of the PMPRB's regulatory reforms. As we continue to see economies reopen, we can all agree that the pandemic is not yet behind us. Canadians deserve to pay a fair and reasonable price for their prescription drugs. However, reductions in prices have unintended downstream impacts on the professional pharmacy services that Canadians rely upon day to day to ensure timely access, safety, appropriateness, and effectiveness of their therapies. And we are concerned that the impacts of the proposed PMPRB regulations and guidelines on patient programs will be severe, and that the implementation of these regulations during an ongoing pandemic will add undue burden on pharmacists and pharmacy teams as they navigate the impact of these changes on pharmacy operations. Pharmacy offer critical supports in areas of testing, vaccinations, and know that we're just scratching the surface of what pharmacy's potential to increase capacity in many public health and primary care areas. We know that there's a huge backlog of number of services, surgeries, chronic disease diagnosis, immunology work together to catch up on, and that requires full scope and capacity to improve access to care for Canadians. With pharmacies across the country now participating in the distribution of COVID tests and many conducting tests on site, pharmacies are uniquely situated to support the health system with disease screening and prescribing and dispensing of antivirals such as Paxlovid. Pharmacies can also create capacity in public health as we catch up on the 1 in 4 Canadian adults and up to 35% of children who have missed or delayed a routine immunization due to the pandemic. Evidence demonstrates that convenience is a key driver to vaccine uptake, and the accessibility of community pharmacies provides convenience like no other. There's a lot of work ahead of us and to not only alleviate strains of COVID-19 pandemic placed on our healthcare system, but also to ensure that equity and equal access to services are delivered to underrepresented communities from coast to coast to coast. Neighborhood pharmacies and our members remain committed to working with the federal government and all stakeholders to leverage the expertise of our teams to create capacity and fill gaps in care. Thank you once again for this opportunity to speak with you today, and I'd be pleased to answer any of your questions.
Thank you very much, Ms. Hanna. As was indicated as a result of Mr. Barrett's point of order, we're now going to suspend, just for the benefit of witnesses, I want you to know that in 17 minutes, members of Parliament will be casting a vote. If they decide to go over to the chamber to cast that vote, we'll be looking at a delay beyond that 17 minutes of at least another 10 to 20. So this is a chance for you to stretch your legs, get something to drink, and that would be to resume to take questions subject to a motion for adjournment. But as of right now, we're suspended, and you've got probably 25 minutes or more to yourselves. The meeting is suspended. Thank you. I understand that we have quorum, and I see that our witnesses have their cameras off, but they're filing back in. So before we begin with rounds of questions, I would just like to advise the committee that we do have support from the House of Commons to go 80 minutes. But that is 80 minutes beyond what the witnesses had committed to, and the members. So I'd be interested in hearing whether there have been any discussions in the room and whether there's any agreement as to how long folks are willing to go, subject to the availability of our witnesses, or if we just want to start and call for a motion for adjournment could be presented virtually at any time. Mr. Barrett, do you want to lead off?
Just on that point, Mr. Chair? Or,
yes, please.
Okay, so I think there were some discussions. I'm not sure that we have a concrete time. I can say that Conservative members are prepared to fulfill the 80 minutes remaining of House resources, provided that witnesses are available.
Well, I would suggest that we begin, and at the end of 2 full rounds, we canvass the room. I'm looking at the witnesses. Are you able to stick with us for an hour, or maybe an hour and a little more? Thank you. I see thumbs up all around. We're going to begin now with rounds of questions.
Mr. Chair, if I may
Mr. Davies, sorry,
motion,
go ahead. Yep,
Thank you.
Go ahead.
Well, I'm mindful of the fact that we're now beginning the questioning at the time that the committee meeting was supposed to end. And I appreciate the 80 minutes. I cannot stay longer than 6:30 at the absolute latest. So that's a hard exit for me. And I'm sure the witnesses who have been waiting since 3:30 Eastern, I'm not sure that how much time they have either, but out of respect for their time and those of us who have other obligations to go to, I would say that there should be a hard stop at 6:30. That would give us enough time for 2 rounds, I would think.
That would give us 2 full rounds.
Yeah. Or so maybe 2 rounds. If we can maybe just agree to do 2 rounds, or 6:30, whichever comes first.
Yeah. Well, I'll ask for a meeting to adjourn I'll ask for a motion to adjourn at 6:30, and hopefully that'll carry the day. Very well. We're going to begin then with rounds of questions, beginning with Mr. Barrett for 6 minutes. Mr. Barrett, you have the floor.
Okay, thanks very much, Chair. And through you, Mr. Chair, to our witnesses today, I just want to extend my sincere thanks for your appearance today, and also for your patience as we engage in democracy, voting over in the House of Commons. So thank you very much for your patience and for your statements today. So I want to go back to Dr. Bogosh. It seems like you spoke quite a while ago now, but you spoke about that we can't cancel surgeries anymore. We can't be closing businesses, and we can't close schools because we have the tools to make sure that that's not necessary. And I agree. And I'm wondering if you can take a moment to expand on some of the ways that we can innovate to increase capacity in our healthcare system.
Wonderful. Thank you for that question. I mean, obviously, we could spend hours on this, but I'll be as brief as possible. In terms of expanding healthcare, I think we have to be a little bit creative as well. One is we need more people working in healthcare, and we need more beds. That's a solid investment over time and a solid investment to train individuals. We also have very skilled healthcare providers in the country who are not able to work. These are internationally trained graduates and foreign medical graduates, and again, they're involved in multiple healthcare professionals beyond medicine, nursing, and other allied healthcare professionals that are not able to work because Canada has not accepted their credentials. And there's a lot of red tape in Canada preventing them from work. So we actually have way more healthcare providers in the country than are mobilized at this point, and they're eager to work. And that's certainly an area that we can explore further. Related to preventing shutdowns. I mean, we do have the tools. We have very simple tools like masking. Again, masks alone don't stop a wave, but they certainly blunt a wave. They protect vulnerable individuals. We have vaccines, and we have a growing array of therapeutics that are slowly launching in outpatient settings. That's really good. I mean, that vaccines keep people out of hospital. Therapeutics can keep people out of hospital. We just have to have timely and equitable access to this, which, again, my pharmacy colleague on this call will be much better prepared to answer this than me. But pharmacies and pharmacists are in every neighborhood. They're accessible. They can do the testing. They can do the treatment. I appreciate there's drug interactions. Who better to look at drug interactions than a pharmacist? They're qualified healthcare providers that can provide timely access to healthcare on the neighborhood corner without some of the barriers that exist with more traditional aspects of care, like seeing your primary care provider. So, I mean, we can expand on all of those fronts, but we do have the tools, and we'll have a growing array of tools to really help prevent people from getting sick and landing in hospital, such that we don't have to, for example, cancel scheduled surgeries like we've seen in the past.
Well, thank you very much for that answer. And so with that...
Mr. Barrett, sorry to interrupt. I just got a note from the clerk that we're going to lose Ms. Shields in about 10 minutes. So I just wanted to alert you to that. If the next couple of questioners have questions for them, go ahead, sir.
Thank you, Chair. And so following up on Dr. Bogosh's point, Ms. Hanna, what are the regulatory burdens that restrict the ability of pharmacies to expand their service offerings to complement and to support our overwhelmed healthcare system in some of the ways that both Dr. Bogosh mentioned, but also that you mentioned, ma'am, in your opening remarks?
Thank you. Yes, and Dr. Bogosh mentioned it, and he stole a word from my mouth. Absolutely. Pharmacies are not only in every community, and pharmacists not only in every community, but we're also supplied by a very robust supply chain that improves timely or allows to have timely access to these therapies in every single community. At the moment, depending on the province, and obviously the jurisdictions vary, the provinces vary in terms of scope of practice and ability for pharmacists to prescribe certain products. And Dr. Bogosh mentioned, that they should be available without prescription, and pharmacists can still counsel and still supply and still educate and ensure that those products are made available to the right patients, and that that is done in an equitable and accessible and safe way. So in terms of regulatory barriers, if it is not a prescribed product, really it's a question of supply, it's a question of access, and it's a question of it being available through the pharmacy sector, which in many provinces right now it is not. It is restricted to primary hospitals. Testing or public health centers. So, I think it's more of a planning question and making it accessible to the pharmacy sector, to make accessible to Canadians.
Okay, well, thank you very much for that. And I have just under a minute left, and we heard talk about vaccines and the availability of some of these different products. And so just with my remaining time, Chair, I just wanted to provide committee with notice of a motion. I'm not moving a motion. I'm providing notice to the committee. It's been sent to the clerk in both official languages, and it reads that pursuant to Standing Order 1082, the committee undertake a study on the government's role in the development and procurement of the Medicago vaccine, and that the Minister of Innovation and Minister of Health appear before the committee to testify. So that's also being made available now to the clerk in writing, in print, in both official languages. And just with my last 5 seconds, I do want to again thank all of the witnesses for your patience, your expertise, and your ongoing advocacy for the health and well-being of Canadians. Thank you very much.
Thank you, Mr. Barrett, and thanks for watching the clock. Next, we're going to go to Mr. Johari for 6 minutes, please.
Thank you, Mr. Chair, and thank to all our witnesses. We really appreciate your patience and your insight into the topic that we're talking about. As Ms. Shield will be leaving soon, I'd like to also thank my colleague for allowing me to take his place. But Ms. Shield, welcome to our committee. You and I have been working on the mental health front in the York region for us very closely in York region for the past couple of years. In your opening remarks, you talked about youth services, and also you talked about integrated care. first of all, I want to thank you for the work that you're doing in York Region community as the CEO of the CMHA, but I also want you to provide us some insight into the innovative initiatives that's currently underway by your branch, which is the Mental Health Crisis Hub. If you could kindly talk a little bit about it with the view of integrated care and the community base, as well as why is this leading in Canada, and how can our federal government support you? Floor is yours. I think you're on mute. I think Ms. Schild might have gone.
Yeah, she's still on the screen, but her camera and her mic are off. Great. Do you have another question, Mr. Johari?
No, I yield my time to my colleague, Dr. Pawlowski.
Dr. Pawlowski, please.
Okay, Dr. Bogash, I wanted to ask you about medical therapeutics. So in the last 2 years, have you been on a number of committee meetings together, and you've probably heard my questions about this. In Ontario, we now have two forms of therapeutics that I think are fairly readily available. Paxlovid, an antiviral, and also sotrifimab, a monoclonal antibody, and both have been shown to be quite effective in preventing hospitalization and serious illness when given early to high-risk people. So off the top of my head, my numbers were sotrifimab, 80% reduction in hospitalization. Paxlovid, I think the original studies were 90%. Now those are probably out of date. But it would seem to me that this ought to be a big part of trying to ensure that future waves don't end up shutting us down. When people who are high risk get sick, they should be able to access these treatments, and thereby we can prevent a lot of hospitalizations, ICU admissions, and deaths. Now, let me start off by asking, are you using those forms of therapeutics very much, and are doctors in Canada using them as much as they ought to be?
Thank you. Thank you for your question. Yeah, this is obviously a very a rapidly expanding area in Canada. And just to rewind for a second, earlier in the pandemic, we had some very good therapeutics for hospitalized patients. Have a armamentarium of therapies for non-hospitalized patients, with the whole role and the goal is to prevent people from getting sick and landing in hospital. There's been hiccups, unfortunately. So sotrifimab, for example, and the other monoclonals don't seem to work very well against the current strain or the current variant, Omicron, and they're not being used or not being recommended. Paxlovid is in very short supply and has a very narrow range of use and has to be used very early on in the course of illness. It has to be initiated within before 5 days of the onset of illness. This really dovetails beautifully with our conversation we were having earlier about getting therapeutics out in as quickly and in a low barrier manner. For example, of course, family physicians, maybe emergency departments, maybe dedicated COVID centers, but also pharmacies and pharmacists, because they're available, they're everywhere. Pharmacists are highly qualified healthcare providers, and they can provide this quickly. They also can do the testing on site and respond to that test in real time by providing a drug that's needed in a very timely manner. So we are using these drugs. We're using them to a limited degree because we have A, limited supply. B, unfortunately, Omicron took the monoclonals out of our toolbox because they just don't work as well. There's a few others that work okay in an outpatient setting, for example, remdesivir. But again, that's an intravenous drug, so it's a bit more challenging to use. With time, we will have more access to, and more drugs available, and we can put those to good use.
Now, my impression, and this impression is because I don't have enough to do as a member of parliament, so I work Saturdays in a walk-in clinic, and I see quite a few people with coughs, and nobody's doing PCR anymore. Everybody's doing rapid testing, and everybody knows the drill. You know, okay, it's negative the first time, we'll test tomorrow, and the next day it becomes positive. And so they're quite familiar with it. But I don't think, and correct me if I'm wrong, I don't think a lot of the public knows that therapeutics work or are available. And so I'm a little worried that a lot of people who could be getting treated aren't getting treated because there's a lack of awareness that if you are high risk, if you're 65, obese, and have had one shot, maybe you ought to be getting Paxlovid or something.
I share 100%. Back to my 5 minutes of time I had earlier, I think it's extremely important to enroll social scientists, communications experts, and really in culturally appropriate manner so that they're aware that vaccines are widely available and necessary. Therapeutics are increasingly available. Here's how you get them. Here's who, and we can go a long way. We certainly are underutilizing our social scientists and our communication experts because there are populations at risk that remain at risk that will have growing access to these drugs, and they're being underutilized.
Thank you, Dr. Bogosh and Dr. Pawlowski. Suite, Monsieur Thériault.
Mr. Thériault, you have the floor for 6 minutes. My turn, okay. Thank you, Mr. Chair. Dr. Falcon, I'm really pleased that you accepted our invitation. I hope there will be as much innovation and innovative approaches emanating from your center as expected. I only have 6 minutes here, but I would like to address a few issues. First of all, risk factors, the effects of vaccines on long COVID we're talking. Symptoms, why does it seem to be more prevalent among women? What about recovery? How about the effects of long COVID related to the fact that we're not really doing as many PCR tests at this point? What effects does that have? I'd like to start. With respect to risk factors, are there any specific risk factors that could accentuate or long COVID or worsen it? I realize also that there are questions I might be asking at this point that you may not already have answers to it. Thank you very much for your questions. They're very interesting. We have some initial answers to your questions for sure. Now, as to the risk factors, there is an association with how the acute illness actually transpired. If the illness was more severe than long COVID, it can also happen. But that can also be the case among asymptomatic patients who had no symptoms, obviously, during COVID. We do see an increased number of women. We see an association with type 2 diabetes. There's also noted associations. Oops. The sound cut out. There was an aspect relating to prior asthma, prior mental health issues, and another association with comorbidities before the initial COVID-19 infection. In more recent papers that are more in terms of fundamental research or basic research, we see some relationships with antibodies. That's in the field of research. When you have high viral load also, you might have more chances of this, and also in the case of Epstein-Barr virus resurgence. There's a team in Germany that has developed a tool to calculate risk. It uses some of the clinical data that I already mentioned, relating to immunoglobulin. These are some of the risk factors. Question. We know that Omicron, for instance, is less virulent but more contagious, spreads more easily. Can this have an effect on the prevalence of long COVID Could there be an increase in long COVID? Have you noticed one relating to these more highly contagious but less virulent types of variants? Or is it more the other way around, where highly virulent variants cause long COVID? That's an excellent question. Here we have to look at two factors: virulence and also the contagiousness of the variant or the virus. We also have to look at the host vaccine level. The rate of vaccination reduces the risk of long COVID. Specifically on this subject, studies have not been peer-reviewed in large part, but data seems to decrease by 50% of risk of acquiring long COVID if people have been vaccinated. So we have to take this into account. There are far more cases, yes, of course, so that could mean an increase in the prevalence of long COVID. But in a context where the illness might be less serious, the host is vaccinated, my expectation would be that, proportionally speaking, there would be fewer cases of long COVID. That is our hope. That being said, we are already detecting in our clinic patients who have symptoms of long COVID after having had an Omicron infection. So in summary, are you saying that the fact that a person is vaccinated means that there is some form of protection, additional protection? And does that in some way prevent the most serious types of results or symptoms? Answer, yes. Question, do you think a fourth dose of vaccines would be needed to protect people from long COVID? I feel at this point that the data remains to be determined based on the preliminary data that I've seen as to the fourth dose. There seems to be a very modest improvement due to that fourth dose. In fact, we would need vaccines to be adapted to the emerging variants so as to have an effect on long COVID. But that, I say this with great reservations because we still are lacking some data on this. We need a lot more data. Thank you. There are a number of people who have had long COVID. Sorry, Mr. Thériault, you have 1 minute. Unfortunately, the interpreter heard two people at the same time. Could you, Mr. Thériault saying, could you talk about... Sorry, did you hear the question, Dr. Falcone? A brief answer, please. I tried to interrupt Mr. Thériault unsuccessfully. Yes, so this is subjective, the term you were referring to. People feel as though their ability to, how can I put it, to process, sorry, that's an Anglicism I'm using, to process new data seems to have slowed. Their cognitive capacity has reduced. Their perception capacity is such that things seem foggy. Thank you, Mr. Thériault. Dr. Falcone.
Next, Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair. Thank you to the witnesses for your patience and your excellent testimony. Dr. Bogosh, 2 days ago on Global News, you said the following: I think we should be wearing masks. I really do. We are seeing a rise in cases throughout the province. There's the wastewater surveillance signals that are up in most jurisdictions, not just in Ontario, but in many parts of Canada. There's probably more COVID in the community now than there was a week or 2 weeks ago. My question to you, Doctor, is do you believe it's premature to lift mask mandates in Ontario or across the country?
Thank you for that question. Yeah, my personal bias and my personal opinion is that it is too soon. Just because mask mandates are lifted, it doesn't mean you can't wear a mask. We can all still choose to wear a mask, and I hope that many people are choosing to wear a mask, given that we are seeing more COVID now than we were a few weeks ago, and we are in the midst of a wave. Just depending on where we are, that size of the wave might be a little bit different. I think we should be wearing masks now, and I'm continuing to wear a mask in indoor settings.
Right, though, Doctor, in assuming that if there were a mask mandate, that would probably result in more people wearing masks than if it were purely voluntary?
Yeah, I certainly agree with that. When we do see that mandates indeed do work, I don't know. I truly don't know what proportion of people are wearing masks now that the mandate have been lifted, but I think it's that if there was a mandate, we would still see more people wearing masks if there was a mandate than if there was not.
Just looking for a yes, no to this. Would I be
Yes.
correct in my thesis that wearing a mask has salutary effects in helping to spread to some degree, helping to spread the prevalence of aerosolized or droplet-based illnesses?
Yes.
Thank you. Also, the subvariant of Omicron known as BA2 appears to be more transmissible than the original strain BA1 and is currently fueling outbreaks in Europe and Asia and, in fact, other places around the world. In your view, Doctor, have we reached the endemic phase of COVID-19?
No, I don't think we have. Endemic means different things to different people. I don't think we're at an endemic phase. We're probably on our way, but I don't think we're there just yet.
Thank you. Now, Mr. Hunt, in a December 2021 article from CBC News, you noted that Canada's PPE industry was feeling, quote, betrayed by the Canadian government because it's not buying from small homegrown companies after encouraging them to step up to deliver the critical supplies. You were quoted as saying, what we've seen is the exact opposite, buying only from multinationals, buying only commodity products, locking healthcare workers out of new and innovative products, and essentially decimating the new PPE industry. Can you expand on that, Mr. Hunt?
Today, Mr. Davies. Initially, the government in March of 2020 made a plea to Canadian industry to stand up a new PPE industry and made a promise to the Canadian public that they would be partnering with Canadian industry to deliver solutions for COVID. And I'll quote here, with a view to longer-term support, the Government of Canada will ensure procurement flexibility to support innovation and build domestic manufacturing capacity to supply critical health supplies to Canadians. And that has not happened. So the federal contracts given to the Canadian PPE industry, the members of CAPM, Canadian Association of PPE Manufacturers, are zero. The contracts that have been given to the two multinational companies amount to about $600 million. That amounts to essentially an active measure against the Canadian PPE industry in that $600 million in potential market is taken away, and there are essentially crumbs that are left.
Same time, in December 2021, the House of Commons unanimously adopted a motion calling on the federal government to supply Canadian-made PPE in the parliamentary precinct and the various federal departments, agencies, and organizations by January 31st, 2022. At the time, you said the following in response, Mr. Hunt: CAPM and its members across Canada wholeheartedly applaud yesterday's unanimous motion. Can you confirm if the federal government successfully implemented this motion by the January 31 deadline, or indeed to date?
We received a letter from the House Speaker to confirm that they would comply by January 31st, and I believe that has happened. We received a letter from the Minister of Procurement, or a designate of the minister, to suggest that they would be following the rules for federal departments and organizations. We're very encouraged by that, but it was also followed with a comment that they no longer need PPE or have a demand or desire for PPE, but if they do sometime in the future, they will consider buying Canadian PPE.
Now, I think in your testimony, if I have it correct, Mr. Hunt, you said Canada's 8-week supply of N95s will be gone in 8 days. Can you explain that for us, Mr. Hunt? How can an 8-week supply be gone in 8 days?
Right now, we currently supply N95s to healthcare and to various federal, provincial, and territorial governments through central procurement. If we have a particularly lethal variant that comes out and we want to protect our entire populace, 38 million Canadians, that's almost 100-fold increase in the amount of PPE that we would need, or respirators, N95 respirators that we would need, and there is no capacity currently to be able to support something like that.
Thank you, Mr. Hunt, and
thank you,
Mr. Davies. You got a lot in those 6 minutes, Mr. Davies. Next, we're going to go to Dr. Ellis, please, for 5 minutes.
Mr. Chair, and thank you, of course, to the witnesses for being here. I'd like to start with Dr. Bogosh. We've talked a bit about increasing mask use and things like that. Are there particular benchmarks or metrics, Doctor, that you think we would need to make Canadians aware of to increase their mask use?
I'd have to think about that a little more closely, but I think that would be very easy to come up with. And, when there was X burden of COVID in a particular community, it could be recommended to wear a mask at a certain point. Of course, mask wearing would be voluntary at any point, but yeah, that's something that certainly could be modeled and discussed with an interdisciplinary team.
And perhaps a big ask, Dr. Bogosh, but is that something that you'd be willing to do a one-pager on for this committee?
Yeah, I'd be happy to help with that on that front.
Thank you for that. I appreciate that. With the change in the way we do testing these days, certainly originally we talked about restrictions and lockdowns, mandates, et cetera. We were really related to case counts, Dr. Bogosh. Is it fair to say now we should be more focused on hospitalization than case counts, especially where we're not doing as much testing and certainly no contact tracing at the current time?
Yes, I would agree with that. I think we have to look at other metrics because we don't have that accurate daily case count. Hospitalizations, unfortunately, and deaths are a delayed metric. We should be acting far before we see a rise in hospitalizations and deaths. And I think wastewater surveillance is a wonderful surveillance tool that we can use. Low impact. You can get a good view across the country of what the COVID situation is like, and we should be acting on those signals in addition to the other metrics that we have.
Excellent. And, when we talk about using rapid tests, especially on asymptomatic people, we realize that these tests are really not very sensitive at all. Does that really make any sense to continue to push using rapid tests on asymptomatic folks?
I think they're excellent tests when they're used in the appropriate context. They answer the question, am I transmissible to other people right now, yes or no? Which is slightly different than the question, am I infected with COVID, yes or no? So some people test negative, but they end up being positive for COVID. But the real issue is their test is negative because you might be positive, you're just not at risk or at much lower risk of transmitting to other people at that time. So there's still a time and a place for rapid testing, and many people might continue to use those before they have, for example, an indoor gathering or perhaps meeting with a more vulnerable individual. I really think we should have tremendous access to these in the community setting so people can choose and have the option to use these tests in the right places. But of course, we need some significant access and public education on when and how to use these tests.
Okay, that makes better sense. Thank you. A couple of other things you talked about was using behavioral scientists, communication experts, and yeah, I think you tied that into vaccine hesitancy. Is that kind of the idea that you had around that, Doctor?
Yeah, I actually think of it in a much more broad manner. We want people to make smart decisions for themselves and data-driven decisions for themselves. The data is changing with time. Policy is going to change with time, and we have to keep 38 million people up to date and in touch with doing the right thing. There might be a time to go get a vaccine. There might be a place to go get a therapeutic. There might be a time to put your mask back on, and we have to reach all 38 million of us to inform people in a proper manner, and also have the public trust and public buy-in to do that when it's the right time. And that really does involve solid communication experts and social scientists to be part of the team.
Suffice it to say, no reason to respond, Doctor, but name calling is probably not part of that buy-in and building public trust. Is that fair?
Agree. Yeah, agree in full.
Thank you. Mr. Hunt, a question around the stockpile and N95s in particular. Maybe you could inform the committee, sir, what the shelf life of an N95 mask is. Unused, that is.
Yeah, they're rated by each manufacturer, usually a minimum of 2 years and typically up to 5 years.
And the burden for storage, is that significant? Obviously we need a fairly good-sized facility to do that. Does that exist in Canada?
I don't believe that just putting respirators suggested a first in, first out rotating inventory system, vendor managed system, similar to what is done in pharmaceutical industries, for example. So for example, if Canadian manufacturers were supplying to the healthcare industry, so there was a constant in and out of inventory, we could actually hold inventory in each of our plants at 20 or 30 companies across the country. So we'd have decentralized warehousing and local distribution, and we'd have a constant fresh supply of PPE at all times. And I really think that's probably the best path for us going forward. Putting them in a warehouse where they're forgotten is probably the worst thing that we could do.
Thank you, Mr. Hunt. And Dr. Ellis, next.
And my wife's a pharmacist. I want to say how much I love all pharmacists.
Back to Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and once again, thanks to all the witnesses. I'll quickly go back to Ms. Shield. Welcome back, and thank you for agreeing to stay back. I like to focus on one of the innovative initiatives that's currently underway in your branch in York Region, which is the Mental Health Crisis Hub. Can you start giving us a little bit of a background about this project, specifically with the youth services and integrated care lens that you talked in your opening remarks? And please.
Thank you. Our branch is leading the development of a first in Canada, as certainly a first in Ontario, 20-bed mental health and addiction crisis hub. For those familiar with the Centre of Addiction and Mental Health, CAMH, it's similar to the CAMH Emerge model, except this is 12 and up and actually integrated with community supports. So it will be staffed by physicians, psychiatrists, nurses, so that they will be able to offload from ambulance and from police. But the difference is, instead of simply treating it like a hospital, we are embedding community support. So each person that comes in and their families will get the services that they need to crisis stabilize, withdraw from any substances that they need to, but also in the hub get connected to ongoing community care. Because as we know, people who are in crisis who leave hospital may not get connected to the services that they need, causing them to return to the ED or worse, have mortality. So this model, which has been supported by the Centre for Addiction and Mental Health, but all three local hospitals, the police, the paramedics, primary care, because that's really important, and all of the mental health and addiction partners and social services partners have come together to design a model that thinks about how we take people in to de-escalate, but also how do we ensure that people who leave get the services that we require. And this model is something that we are sharing as we build it, because many communities are interested, because we know that one of the main reasons that people end up returning to mental health services is they're not connected to the right ongoing supports, particularly in that post 24 hours and 7 days after care.
Thank you. Can you shed some light to the timeline of this project, and where are you within implementation and rollout of this project?
It's a great question. So we are right now working with provincial capital funding to try to establish the capital planning requirements. So we seem to have completed our functional plan and are waiting for final sign-off, and are hopeful that that will happen before the provincial government drops a writ, so that we get our next tranche of funding.
Quickly, what does federal government can do? I understand you're working closely with the provincial government. What can we do on the federal side to be able to support you?
I really believe that this is a multi-government approach. We have a lot of municipal support as well, and the federal government can also step up with supporting access, supporting how this can support our newcomer and refugee population. I talked about an integrated model as well. This can't be siloed. We are trying to leverage all of the people who support mental health into this hub, because people are getting services from different communities, including the federal government. So they have to be at the table and helping the design of this, and then supporting the funding of it, so that those services that are connected have the staff to help connect them. Because it's not just about the team in the hub, but it's a team of people that are going into the hub that connect people after. So those resources, this hub will only be another bottleneck if we don't have the services for people after they are in crisis.
Can you briefly talk about how this concept will actually reduce the burden on the healthcare services at the primary sources that we are accustomed to?
So right now, as we know, there are many busy emerge departments or police, and they're taking people to hospitals for care, often as a first source, or people don't know where to go for care. So with this 24/7 designed for people to be welcoming, to get the services and connected to the services they need. It supports access, it supports navigation, and it de-escalates crisis. All three things are the major cause of people escalating or their symptoms escalating. So we know for sure that people who are connected to care are less likely to return to emergency departments. We know that people with serious and persistent mental illness need welcoming spaces to go, where they are welcomed and not treated as if they are quote unquote frequent flyers, but actually seen as welcomed into the care that they need, where they can go somewhere, even if it's just to have that socialization, and so that they can get the support. So it'll reduce the burden that's on hospitals in dealing with patients that would be more appropriately serviced in community, as well as supporting clients and families as young as 12 years old to get connected to care easily, quickly, in an integrated manner.
Thank you, Ms. Shields. And Mr. Johari, suite M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Thank you, Dr. Falcon. You raised this earlier on. You briefly mentioned that women are far more affected by men by long COVID. Up to 80% of cases are in women. Do you have the beginnings of an explanation for that? Yes. I think in this case you have to look at 2 points. First, there's a biological aspect, and there's also the socio-psychological aspect. On the biological side, one of the assumptions that I would raise is that we believe there is definitely an autoimmunity aspect to long COVID, meaning that the infection can launch a process whereby the immune system attacks proteins or molecules that are part of the self, if you will, and this generates dysregulation, inflammation in the immune system in general. We know women are predisposed to this type of thing. So that is sort of the start of a biological explanation. The other aspect is perhaps more societal in nature. Women may have more of a tendency to be referred in external clinics. When individuals have not been hospitalized in the clinical phase, there we find far more women with long COVID often. This often happens when there's been a much higher viral load because of the work that women do professionally or even personally, the way they experience life. That could have an effect on long COVID. The proportion of what is the ratio of people who recover from long COVID? Is that a high ratio? Relatively speaking, yes. What we're seeing is that a large number of people, but from 4 to 12 weeks after infection, do recover, according to some definitions.
Environ 20% qui va aller.
That cut out for the interpreter. Many people will be better from 3 to 6 months later, but I think there are some patients. I mean, it's difficult to detect exactly, but I would say about 15% to 20% of people could have complications beyond 1 year. We even see people now who have symptoms 2 years post-infection. Thank you.
Mr. Thériault. Next, Mr. Davies, please, for 2.5 minutes.
Thank you. Mr. Hunt, your association has stated that federal and provincial procurement still relies on outdated tendering criteria that give advantage to offshore producers who, in some cases, in your testimony and in your press release, say are dumping product below cost into the Canadian market. You, Mr. Hunt, were quoted as saying, by not recognizing Canadian content or high product standards, our procurement systems are also allowing products of inferior quality into our hospitals and homes, and far too often those products are coming from jurisdictions with poor labor and environmental practices, as you've testified today. How prevalent, Mr. Hunt, is this, and what do you suggest be done about it?
Well, the first thing we need to do really is to eliminate the tariff exemption that was put in place in the early days of COVID. So $19 billion worth of product, including PPE, has been purchased under that tariff exemption, amounting to about a $3 billion subsidy of foreign goods or lack of protection of domestic industry. It's very prevalent still, the amount of defective or counterfeit or a contaminated product that comes into this country. 99% of Health Canada's safety alerts and recalls on their website related to PPE are from offshore. And so we see this continually. We would like to see the standards updated to include the new CSA standard that just came out for Canadian N95 respirators. And we would certainly like to see better standards for medical masks in procurement.
Dr. Bogosh, we know vaccine effectiveness wanes over time. It seems efficacy is substantially reduced. It seems about 3 or 4 months post-jab. How long after the third booster is efficacy substantially reduced? And what do you think is a good long-term plan if that's the case, given the European Medical Agency has stated that they don't think we can boost ad infinitum?
Yeah, I mean, this is clearly an issue. One of the key points here, though, is that 2 and of course 3 doses of a vaccine, while the efficacy wanes more significantly for protecting against infection, you still see very significant protection with 3 doses against severe outcomes like hospitalizations and death. Having said that, that also starts to wane a little bit, but not as significantly as versus getting the infection in the first place. I think we'll see 2 things. One, we'll probably have, and this is speculation here, we'll let the data drive the policy, but we'll probably see annual vaccines similar to what we see with influenza, not vaccinations every 4 or 5 months. And on top of that, we'll probably have more updated vaccines reflective of the circulating variant du jour. Currently, we're still using vaccines for the original virus that emerged from Wuhan, but we'll probably see some updated vaccines for Omicron or other variants shortly.
Thank you, Dr. Bogosh and Mr. Davies. Next, back to Dr. Ellis, please, for 5 minutes.
It's actually going to be me, Mr. Chair, Mr. Lake.
Go ahead, Mr. Lake.
Yeah, my question's going to be focused. Our questions are going to be focused on Dr. Bogosh. There's so much noise out there right now, and I'm convinced over and over again that despite that noise, everyone wants to be healthy. No one wants to screw up their lives. We all want to thrive, and it's increasingly difficult to make the best decision you can with all the noise that's out there. What do people believe? I'm going to put you on the spot. What do people believe out there right now broadly that just is not people broadly, but what do a number of people believe that just isn't correct about COVID?
I think there's still some skepticism toward the utility of vaccination in some proportion of the community, not a large proportion, but some proportion of the community. Maybe some thoughts on therapeutics that might not be as effective, for example, ivermectin or hydroxychloroquine. But I think your point is significant in that it raises a much larger point in that we do have significant issues, even in Canada, more in other places, but still here in Canada, with misinformation and disinformation amplified online that drives bad behavior, behaviors that aren't really associated with healthy outcomes. And I think we need to have, this is obviously a much bigger discussion than why we're here, but obviously there has to be a coordinated effort to combat misinformation and disinformation because it is impeding healthy outcomes.
For sure. And I'd love to follow up on the conversation. So please reach out to me after this because I want to have a longer conversation with you. But complementary to that question, where is the most common agreement amongst medical experts, even medical experts who might have differences of opinion with you on some things? Where is the most common agreement on COVID science?
Vaccines are extremely safe and effective.
Okay. You talked about masks. We live in a real world where some jurisdictions are removing mask mandates and some people just don't want to wear masks and they're not going to. Setting aside masks, because you're very clear on the science around masks, and many experts are, what other things can people do to stay safe in their homes, when they're indoors? What other advice would you have beyond just masks?
Sure. So just 1 second to go back to my last statement. I would say that the vast majority of people in medicine and science would say that the vaccines are safe and effective, and you have a small but very vocal group suggesting otherwise. Getting to your more recent question, Masks, of course, are helpful, but we have other tools that are also very helpful as well to create safer indoor spaces. Rapid testing and rapid testing before going into an indoor space is very helpful. Creating better ventilation in indoor spaces is also a helpful tool. Vaccination, of course, still, while it's not perfect in reducing the risk of infection, it does lower one's risk of infection, just not to the same extent as it did with earlier variants. Those are all helpful tools to create a safer indoor space. And I think, these are multi-layered tools. So no one tool is perfect, but when you add them all up, you have a synergistic effect.
I'm going to try and get the most out of my time here, moving to testing and therapeutics. So if you test and you test positive faster, the therapeutics sounds like have more effect, obviously, if you take them sooner. If in a theoretical world where everybody that tests positive right away, would everyone benefit from a therapeutic?
No, it really is the highest risk at this point in time. And that's key, is getting the high-risk individuals timely access to those therapeutics.
And then on testing, there's lots of misconceptions, I think, around testing. How accurate are the rapid tests now?
I think it's hard to give a number because the rapid tests answer the question, am I contagious? Not am I infected? Am I contagious right now with COVID-19? So they're actually very good at addressing that question. You might be a positive case, but not contagious to others because you haven't built up enough virus in your system, and your rapid test will be negative. But the test answers the question, am I transmissible to other people? It's very good at doing that.
Is it accurate to say that the thing that registers on the test is the same thing that makes you contagious to people? Is that sort of in a simple way of thinking about it?
We'll go with that, sure.
Okay. Thank you. So I'm now a medical expert. On serological tests, is there a value to serological testing right now?
And so you can ask 20 people and get 20 different answers. I'm a little disappointed in serology. I think it does have some utility, but it has less utility than we thought. It's really good more in an effort epidemiologic studies and looking at the burden of COVID in different communities and how that changes with time. It's less helpful, not helpful, just less helpful with meaningful clinical decisions.
Thank you, Dr. Bogosh and Mr. Lake. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, all the witnesses. My question is to the neighbor pharmacy. Ms. Hannah, from several years, pharmacists have been advocating for an increased role as primary care provider, including prescribing authority for certain conditions and medication in some remote communities. Pharmacists may already be the closest resources primary care provider. How do you see this playing a role in addressing human resources concern in the healthcare system? What do you see?
Thanks for the question. We think it's incredibly important. I think as we talked about before, there are many backlogs in the system, whether in primary care or public health, immunization. Pharmacies, as they expand their role in primary care by prescribing, whether it's for common ailments or minor ailments, the majority of the provinces across Canada are already prescribing for this. There are a couple of provinces that are still lagging in terms of pharmacists' ability to prescribe for some of the common ailments. We're talking about things like allergic rhinitis. We're talking about things like diaper rash or cold sores, uncomplicated bladder infections. Pharmacists are prescribing for these things in many provinces, but still a number of provinces do not have the ability for pharmacists to prescribe. And given that authority, we'll be able to help sort of distribute the burden of care between the many providers that we have in the system. So, if somebody's experiencing symptoms of some of these common conditions on a weekend, in an evening, they may be going to the emergency room for that. Is that the best use of our health system resources? Likely not. Much more costly, and they can be much better dedicated to somebody with more severe concerns.
Thank you. My next question is to Dr. Bogosh. Dr. Bogosh, could you speak the importance of wastewater surveillance in monitoring the spread of COVID-19? What trends are we seeing in wastewater in recent weeks?
Thank you. That's a great question. So the wastewater surveillance is an extremely helpful tool, especially when we don't have access to widespread community testing. It gives us an early signal as to where COVID-19 might be on the rise or actually on the decline, although unfortunately we are seeing it on the rise in many jurisdictions. And it's a way to look at early signals for COVID changes and over time, plus tracking the geography of where those changes are occurring. It's proven to be an extraordinarily helpful tool, not just here in Canada, but elsewhere in the world.
Thank you. Next question is Dr. Falcon. Dr. Falcon, you said we need forward-thinking, efficient infrastructure, standardizing protocol for chronic diseases. Can you elaborate on that?
Yes. I think that when it comes to really understanding complex diseases, we really need to arm ourselves with objective data, which is often what is lacking in these types of circumstances for the diagnosis and then eventually for the management of these patients. So having a structure where we have several centers involved, so where we could not only harmonize our data collection, but also pool it together, integrate it, this would be a lot more powerful at getting at meaningful tools like diagnostic biomarkers and potentially therapeutic targets that we could put into clinical trials.
Thank you. Mr. Chair, do I have more time?
Yes, you have about a minute and a half.
Okay, thank you. My next question is Dr. Edmonds. Dr. Edmonds, in 2021, federal government expanded caregiver benefits through the EI program. Could you share with this committee about the specific impact you saw over the last year as a result of this measure?
I'd like to turn it over to my colleague to answer that one.
Thank you for your question. The Canadian Cancer Society pays close attention to the supports that are available for caregivers as well as for people living with cancer. And we are focusing our attention now on the need to increase the employment insurance sickness benefit. And I'd like to take the opportunity actually to thank the government right now, as well as all parties around the table for supporting the extension of the employment insurance sickness benefit. We're also taking time to pay attention to the needs of caregivers in a time when their loved one has passed away. And this current government has also given additional supports for grief and bereavement. So while I know I haven't answered your question specifically, I will get back to you with a better answer. Those are two measures of supports that we have seen over the last short while that will have a long-lasting and positive impact on people living with cancer and their family members. Thank you.
Thank you, Ms. Mazzotti. Thank you, Ms. Sidhu. Colleagues, we have now reached the 6:30 Eastern hour, and so I'm going to ask whether it is the will of the committee to now adjourn. And while we're determining whether that is the will of the committee, I would just ask the witnesses just to hold tight. We will want to give you a proper goodbye if this is goodbye. So is it the will of the committee to adjourn the meeting at this point?
Oui.
Okay. I'm hearing from the clerk that we have consensus in the room. It appears that we have consensus in the room. All right. Before we adjourn, two things. First of all, to the Bloc Québécois and to the Conservatives, if you could suggest some more witnesses to us for the COVID study. We're running low on the witnesses from those two parties.
You could always bring these fine people back, Mr. Chair.
I was just about to say that. Okay. To the witnesses.
Point of order. No sucking up.
That's not a point of order, but it's really good advice. To the witnesses who are here with us, first of all, thank you so much for giving us an extra hour. There was an incredible amount of information packed into the time that we had, for which we are extremely grateful. So thanks for bearing with us. And thanks for keeping your answers concise and extremely informative. It will absolutely be of significant value to us. And Dr. Hanley, do you have a point of order?
a quasi point of order. I just wanted to say, since I didn't have a chance to ask questions, I wanted to express my appreciation as well for both for the witnesses and for my for all my colleagues with their excellent questions. I think this is fascinating and great content that we fleshed out. Thank you.
Thank you, Dr. Hanley. Thank you to all. The meeting is adjourned. Have a good evening.